The success of targeting EGFR, ALK, and ROS1 has spurred additional efforts to identify additional oncogenic drivers that can be targeted therapeutically. Over the last several years, there have been several notable examples with very promising clinical data that we've seen over the last several years. Important examples of this include RET rearrangements, MET exon 14 skipping, and NTRK rearrangements. So taking RET rearrangements as an example, RET rearrangements were first identified in lung cancer in late 2012, early 2013. These were found in about 1 to 2% of patients, and they tended to have characteristic clinical and pathologic characteristics. Like other oncogenic rearrangements, RET rearrangements resulted in RET fusions, and these tended to occur in patients with a light or never smoking history. At the time these were first identified, we didn't really have selective RET inhibitors in the clinic, and so investigators relied on multi-kinase inhibitors that targeted multiple kinases, not just RET. And so early on, the response rates that were seen with these multi-kinase inhibitors were relatively modest compared to other oncogenic drivers in lung cancer. So we observed response rates in the 20 to 30% range. More recently, there have been 2 selective RET inhibitors that have entered clinical testing, and both have shown high response rates, I think confirming our initial suspicion that RET is a bona fide oncogenic driver mutation in non-small cell lung cancer. Like the experience with RET, another emerging oncogenic driver in lung cancer has been MET exon 14 skipping mutations. Here, the pathophysiology is quite distinct. So exon 14 encodes the Sybil binding region in MET, which is important in that it targets the protein for ubiquitin-mediated proteasomal degradation. In the setting of an absence of exon 14, you get decreased degradation of MET, which results in increased accumulation of MET on the cell surface. We found that MET exon 14 skipping is found in about 3 to 5% of patients. And like other oncogenic drivers, it does appear that MET exon 14 skipping mutations appear to confer sensitivity to treatment with MET-targeted therapies. So this does appear to be another driver mutation that may be important to test for moving forward.
Tumor mutational burden on a very simplistic level is a measure of how complex a cancer is, meaning the number of mutations that occur within the tumor. And we found that depending on the assay that you use, you can measure TMB, or tumor mutational burden, by counting the number of what we call non-synonymous mutations, meaning if you have many more mutations, that counts as a high score, versus if you have much fewer, that would be an intermediate or a lower score. The TMB high patients, those have been associated with benefit from immune checkpoint inhibition. And again, this cutoff varies depending on the test that you use. But it seems like there is an association between cancers that are TMB high that have a greater proclivity for response, either the single agent immune checkpoint blockade or the combination immune checkpoint blockade. And so it's one of the potential biomarkers that we're looking at in the immuno-oncology space. Now, TMB doesn't always completely coincide with the level of PD-L1 expression on cancers. And so I think the approach that's favored now is to treat these as overlapping but independent biomarkers. And so if I have a patient who, for example, may have a PD-L1 negative tumor, but really have a high TMB score, I would think very carefully about whether or not I might give immunotherapy to that patient, even though the PD-L1 status is negative.
As the number of targetable genetic alterations increase, it just becomes infeasible to perform single gene tests, one after the other. It really speaks to the need to comprehensively evaluate the genetic landscape of a tumor and do so simultaneously while using the least amount of tumor tissue available. And to that end, I do think that next-generation sequencing using multiplexed assays is becoming the standard of care, if not is already the standard of care at most academic institutions, which really does speak to the need to rapidly assess the genetic landscape of a tumor and do so while preserving tissue for future clinical trials.